Assalamu alaikum, and welcome back to another episode of What's Up, Doc, a health and wellness show dedicated to guiding you through the world of medicine and healthcare. I'm your host, Dr. Aalia Al-Barwani, and I'm a board-certified family physician. My show, What's Up, Doc, is a production of Muslim Network TV, the only Muslim-focused network broadcasting in North America. You can watch all of our shows on Samsung Galaxy 19, Roku TV, Apple TV, Fire TV, and Roku TV. Muslim Network TV also streams live nearly every day, and you can find us on our YouTube page at youtube.com/Muslim Network TV and on our website, muslimnetwork.tv. Today we have yet another exciting episode, and we're going to be talking about the burning issue of acid reflux. Joining us in that discussion is Dr. Fuad Otaki. Dr. Otaki completed graduate and medical degree at the Weill Cornell Medical College in Qatar. He then joined the Division of Genetic Medicine at Weill Cornell Medical College in New York as a research fellow in the fields of personalized medicine and gene-based therapies. His clinical training began as a resident and subsequently a chief resident at Stanford Hospital. He then returned to New York Presbyterian Hospital, Weill Cornell Medical College for a fellowship in gastroenterology and hepatology. In addition to general gastroenterology training, Dr. Otaki undertook additional esophageal clerkships at the J. Monahan Center for Gastrointestinal Health, Columbia University, and University of North Carolina, subsequently completing a dedicated fellowship in benign and malignant esophageal diseases at Mayo Clinic in Minnesota. Welcome, Dr. Otaki. That was quite a mouthful and such an impressive bio.
Thank you so much, Aalia. It's a pleasure to be here, and I thank you for reaching out. I'm looking forward to our chat.
Absolutely. So let's start off by talking and describing what is gastroesophageal reflux disease, which we're just going to call GERD because that is quite a mouthful. Let's talk about what it is and what are some signs and symptoms.
Absolutely. Gastroesophageal reflux disease, or GERD, can be challenging to diagnose because it can present in so many different ways. It's also a disease that has a set of symptoms that are not unique to it, meaning that many of the symptoms we typically associate can be seen and caused by other disorders. Gastroesophageal reflux disease, in principle, is related to an increased acid exposure in the esophagus and beyond. And what I mean by that is obviously the anatomical connection between the stomach and the mouth is the esophagus. Mm-hmm. And if we have a backward or retrograde flow of acid that causes injury to the esophagus or the voice box, the larynx, dentition, and potentially triggering of asthma, then we would consider that signs of gastroesophageal reflux disease. In principle, it's either an increase in acid exposure, or acid comes up and is not swept down by the internal mechanisms of the esophagus, or it comes up at a time when it shouldn't. And the reason I bring that up is it's not a perfect valve where the esophagus meets the stomach. That junction is a two-way stream. In terms of symptoms caused by gastroesophageal reflux, they're often divided into esophageal and extraesophageal. The most common esophageal signs are heartburn, in addition to the regurgitation of food, phlegm, and acid from the stomach up to the mouth. Extraesophageal signs are quite extensive and can be very nonspecific.
Let's stop there for just a second, Dr. Otaki, and just kind of summarize. A lot of that information is super important for our audience to understand. And so when you talk about the description of what happens, to break it down even further, what you're saying, and this is very crudely put, is that it's kind of like splashback. Would you agree? Sort of like things are supposed to be going, you said it's a two-way stream, but sometimes a splashback is excessive and that the contents of the stomach acids kind of fly out of spaces that they're supposed to be contained. Is that a good crude description?
It's a very challenging topic to sort of summarize into a few lines, like many things in medicine. But I think the easiest way I think of it is the majority of flow is progressing from the mouth down the esophagus into the stomach. Any retrograde flow from the stomach upwards typically causes symptoms. There is an amount of it that is considered physiologic, but if there's an increase in the amount, if there's an increase in the amount of content that is coming back up the esophagus, then we typically think of gastroesophageal reflux disease.
Okay. Okay. And then you said that is typically experienced by people as heartburn. And so for people who are not familiar, as I am very familiar, it is literally burning in the center of your chest, feels like your heart is on fire.
Correct. The symptoms of chest pain that have a burning nature, often described below the rib cage, is classic.
Exactly, exactly. Okay, so you were saying there are extra esophageal symptoms that can happen, and I think you'd mentioned some cough. Did you say cough earlier, or maybe you were going to get into that? I'll let you continue.
Thank you. No, extraesophageal signs are quite broad, and the way that patients perceive them also changes depending on their age, their other medical problems, and their sensitization to these symptoms, which is a topic unto its own. But in terms of those symptoms that we often describe as extraesophageal, they do include a change in voice, a recurrent cough, and occasionally a metallic taste in the mouth, amongst others.
That's good to know. So if patients are having a recurrent cough, they can't really figure out where it's coming from, and they've tried other measures to control it, then GERD is definitely something they should also be considering. So it's not always that burning feeling. You may just have that cough and that metallic taste you mentioned as well. That may be a sign of GERD as well.
Absolutely, but I'd also caution our audience in knowing that cough is obviously a very common symptom, and gastroesophageal reflux is very common. And therefore, while they might be associated by virtue of the probability of both of those things happening, it's not always caused where one causes the other.
That's a good point. That's a good point. So don't run to your doctor and say that, this is exactly what I have because I heard these doctors online, which brings us to our disclaimer. And that is that we should definitely encourage our audience to take everything that we say here as not as medical treatment for your conditions, and to always consult with your physician using the information that we've given you, not to take it solely based on without talking to your doctor.
Absolutely.
So you mentioned it's very common. Let's talk about how common it is in the United States, and then specifically because of your practice and your background, I'm sure you must see a lot of it. So let's talk a little bit about how common it is.
In terms of gastroesophageal reflux, the challenge with defining how common it is defining what is considered gastroesophageal reflux. Some have attempted to do that based on the number of symptoms that you have in a set period of time, typically a week. Others have explored the severity of symptoms such that if a symptom requires medical attention. And then finally, some have tried to be more purists and evaluated physiologic parameters to measure acidity in the esophagus in order to truly represent how the incidence or the prevalence of gastroesophageal reflux disease, in other words, how common it is in our communities. Wow. But the general sense is that 3 out of 5 Americans seek medical care for gastroesophageal reflux. In fact, it's the most common indication we see patients, or most common reason, that we see patients in clinic.
Mm-hmm. Absolutely. And I'll share, I recently saw a patient who came in for evaluation for bariatric surgery, and she described chest pain that she had had for a year. So of course, immediately I knew it was most likely not cardiac, having that it has been lasting for a year. She's a young female, no other risk factors. And started telling me about her diet, and she started pointing to where she was calling chest pain, and is just exactly where you mentioned what we call the epigastric area, the area right underneath the breasts for women, right kind of center there. And I was like, well, I wouldn't necessarily call that my chest, but that was interesting that she called it that. And going back to what you said about how symptoms can be kind of varied, as well as how common it can be without patients really understanding that they have heartburn. So let's talk a little bit about the testing that you mentioned, because you said that there is specific testing that can happen for the purists that want to measure the acidity in the stomach. Personally, I tend to really go for clinical history and exam. But let's talk a little bit about if there may be tests, if patients are interested in knowing for sure that it is heartburn, or what they can do, basically.
Absolutely. Thank you so much for asking that. It's important that we also take into account the availability of medical resources when you try to address that question. And so taking into account, like with many diseases, how easy it is to see a physician, and how easy is it for that physician to be a gastroenterologist. But at the same time, often there's delays in care, either because of limited resources, disparities in healthcare, and the list goes on and on. The general idea with reflux is if you have a strong enough suspicion based on the clinical story, which is a combination of the exam and the history, then you can either treat with a effective medicine and evaluate for response, and that medicine is considered a proton pump inhibitor. The classic example is omeprazole, but there are others in the same family. Another approach is if a patient either is high risk for complications or has other signs that we would consider alarm signs, then they should immediately seek care for the purpose of getting an objective evaluation. And that evaluation would be in the form of one of three tests or a combination of those three tests. And those include, in more recent times, an upper endoscopy, which is a flexible tube that has a camera and a light on one end and controls on the other, that is often placed through the mouth and evaluates the esophagus in a patient who is comfortably sedated with some medications. Another test is what's known as an esophagram, where a patient drinks a chalky material and an X-ray is taken, and the chalky material essentially outlines their esophagus and provides some added information. The most accurate test, which is the most invasive test, is a measurement of the pH or the acidity in the esophagus, and that can be achieved either through a wire through the nose, which is an unpleasant experience but not dangerous, or through a wireless probe that is attached to the sort of the skin of the esophagus or the inner surface of the esophagus, and that is placed during that endoscopy I was mentioning earlier.
Okay. So that's good to know. You mentioned that that one of the ways that you can confirm diagnosis is by trying an antacid or a proton pump inhibitor. So would you recommend for our audience or for anyone to first try that? Or in which cases are we doing some of these other measures that you mentioned with the endoscopy, et cetera? What are the cases where that is you usually would do that?
It's an excellent question again, and I want to admit that it's difficult to answer in a very comprehensive way that includes every scenario. But a general idea of how I approach this is that if a patient has symptoms that are classic for reflux, they're young and otherwise healthy, and do not have any of the alarm signs, which include weight loss, difficulty swallowing, a change in the color and consistency of the stool such that suggest that there might be bleeding, or other medical history that would make them high risk, and those would include heart disease, kidney disease. And lastly, there should be special attention taken to what we consider sort of more, not vulnerable, but more at-risk populations, including pregnant patients, patients above a certain age, and that age boundary, fortunately, with advances in medicine, continues to be pushed further and further, but I would currently think of that age group as 60 and above, and then children, of course, which is outside of my specialty. And in those patients, I would suggest moving away from medicine as a trial and instead planning a diagnostic endoscopy or pH test.
That's really good to know. So to summarize, it's really very complicated. And so for children, you said it's probably a good idea to not do the trial and error and to engage in diagnostic testing first. Our vulnerable population, pregnant patients, you'd mentioned as well. Let's talk a little bit about some over-the-counter treatment. You had mentioned some proton pump inhibitors. We are going to jump into that in just a few minutes. We're going to take a short break, and then we'll be back and we'll jump right into that.
Excellent. Thank you.
alaikum. My name is Adam. You remember me? I appeared in so many episodes that Sound Vision has put on the market. No matter what. Hey, what's happening? Hey, oh, sorry. Lockdown is what it is. Well, continuing here. In this lockdown, Sound Vision never stops thinking about you, the viewer. We'll have to get back into production again, online and inline. Everybody in their own space, even me. Although I'm stuck with Lanisa.
Salam! Salam! Salam!
I know, you were shocked too. Well, let me continue. This is what I was going to say. Salam! 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 Cut! Finally, I get my own screen time again. Thank God. And so we invested in new equipment to bring you even better production with new songs and new singers and animations. Well, here are a few clips. And Sound Vision has brought all this into your home, making Islamic values and teachings easy. And if you know me, Adam, a multi-talented actor, well, sometimes I'm an actor and the reporter and the... Oh, that's enough. Let's move on to the next section. Well, you can watch these new episodes on our new app at www.adamsworldapp.com. We have previews happening every day on Muslim Network TV. Sound Vision has been serving generations, moving and changing with the times. We are all faithfully connected. That is a huge blessing. Your donation helps keep these programs available now and into the future. We take this job of helping tomorrow's Muslims today seriously, and you should too. Today, we need your help. Children absorb and learn from everything they encounter. Make that wholesome, positive, grounded in our faith. Together, we can accomplish our goal of raising better Muslims, better neighbors, and better citizens. Please donate generously. It's an investment in our future. But to finish, let me tell you, there are new scripts of my new mission. And it is something that I enjoy talking about. My new mission is space. Houston, we do not have a problem. Salam, see you soon.
Welcome back to What's Up Doc. I'm your host, Dr. Aalia Al-Barwani, and today I've got Dr. Fuad Taki, and we are talking about GERD, or Gastroesophageal Reflux Disease, better known to most of us as heartburn. Before the break, we were talking about some options for the treatment of acid reflux, and Dr. Taki was going to jump in. Walking down the aisles of the pharmacy, there are so many options. There are brand names, generics, there's Tums and Meprazole, all kinds of names. So why don't you walk us through and guide us through what the different medications are for the treatment of heartburn?
Absolutely. If I may, in terms of the way we treat reflux, it's a combination of lifestyle, medications, and surgery. We'll talk about medicine now, And then depending on how much time we have, I'm happy to delve briefly into the others.
Oh, we definitely should talk about the other two, especially lifestyle. I know that that's something that we can talk about for sure.
Absolutely. And in terms of medications, I want to make sure that our audience knows that I have no conflicts of interest and I'm not in any way sponsored or funded by any of these companies. I also want to put a disclaimer that I am all for and happy to incorporate comprehensive care that includes holistic medicine approaches, alternative meds, and therefore my bias is that my training and my focus is in conventional Western medicine, but it's by no means meant to be comprehensive.
And that's great to know. And I would love to hear other, not just medications that we can get over the counter, but other holistic measures. That would be great to hear about as well.
Absolutely. I'll briefly talk about those by way of experience from other patients rather than personal knowledge or sort of dedicated, informed reading or research. And I've heard many examples of patients finding that they can modulate or decrease their symptoms by using things such as aloe vera, and also incorporation of peppermint oil and other herbs. Beyond that, there's obviously a big role for anything that can help center us and desensitize, whether or not it's meditation, prayer, support groups. So I think those all play a big part. And the reason I want to emphasize this is most patients that come to our office are sort of under the impression that the first thing a doctor is going to do is give them a medicine or treat them with a surgery. And while that might be true, it's not necessarily because of the lack of other treatments, but more just the nature of our practice.
Absolutely. I'm so glad that you brought that up, Dr. Otaki, because in fact, you're right. A lot of people, and to be honest, there's, I think, a split. I think some patients do come in expecting a prescription every time they go see a doctor. But then there is a group of people who prefer not to take medications and want to try and make some lifestyle changes or get other suggestions for different ways that they can treat whatever it is they're coming in for. And so I do appreciate that you mentioned that, especially with GERD, because it's so common that there are alternatives. So thank you for mentioning that.
Of course. And sort of going back to your question about how do I sort of categorize the medications that I would see in a typical pharmacy aisle, the way I think of medications for gastroesophageal reflux is currently 3 categories. One category are your antacids, and those are the ones that we've had the longest experience with, and they come in different shapes and types and flavors. And they include your Rolaids, Mylanta, Tums. The general principle of an antacid is a neutralizing chemical that reduces the amount of acid in the top of your stomach. Mm-hmm. It also neutralizes some escaped acid that is in your esophagus. Now, of those antacids, there's very limited research to suggest that one is better than the other, and often we have to be cautious as to the side effects of these meds, which depend on the chemicals they contain. Mm-hmm. And so it's important that you, again, consult your doctor as to what antacid is important. Their availability over the counter indicates that they're safe, but they're safe within moderation. And if you find yourself taking too much of them, it's either because you have the wrong medicine or you have a wrong diagnosis. But moving along, the other category are your antihistamines, and those medications are often used for other things in addition to reflux, including allergies, increased secretions in the nose, what's known as postnasal drip. Of those medicines, we've had a recent recall, and currently what I would consider an available and safe medicine is famotidine, commercially known as Pepcid. I think of that as an effective treatment for the control of majority of reflux, though it has certain limitations. That said, in the last couple of years, we've had a change where, we had a change where a medication that has helped and dramatically changed our practice are proton pump inhibitors. These include omeprazole, pantoprazole, and most of these medications end with the letters AZOLE.
Mm-hmm. Okay, that's good to know. And it's really important with recalls because a lot of times patients do keep medications around that may have been recalled. And if they're not paying attention, then they may be taking a medication that is no longer considered safe. So that's a great point to bring up. Now, you mentioned interactions with other medications, and so that's a really good point also to kind of go back to what you were saying as alternative measures for the treatment of acid reflux. So I'm glad that you did bring that up as well. For the medications, as far as treating with medications, something that you mentioned that I think is really important is that if you are needing to take high doses or frequently that you may have the wrong diagnosis or you're taking the wrong medication. So let's talk about at what point, because these medications are available over the counter, I do know patients frequently reach for them, but at what point should patients be thinking about reaching out to their providers and talking to them about their symptoms and getting a medical professional to weigh in on their symptoms? And that may also talk to some of the alarm signs that you mentioned earlier.
That's exactly where I was going with this. I think I'll first start with the alarm signs, which is weight loss, difficulty swallowing, a change in bowel habits such that you see frequent black stools. Those are not the only alarm signs, but these are often ones that we discuss. Your other sort of physicians may also be worried about things such as anemia or a drop in your blood count, and they may also see signs that suggest that this is an ongoing issue based on inflammatory markers, and there are many of them. In terms of other reasons to seek a physician's care, these are often divided into persistent symptoms despite medications, or the need to take medications on a regular basis to maintain a quality of life.
Interesting. So just to recap, you mentioned weight loss, darker than usual stools or black colored stool, and anemia. And then, as we mentioned earlier, the need for frequent or excessive use of the medication that you're taking to control symptoms. One thing that I do want to say, that patients I have had come in freaked out about their stools turn black, and sometimes it's a result of other medications such as Pepto-Bismol, which can turn the stool really a dark color. So if you are taking that may be the cause for the change in your stool, but I would imagine what you're saying is outside of a medication that can affect the color. If you are noticing changes, that is something to be wary of, correct?
Absolutely. There are certain fruits and vegetables that can also cause a significant change to your stool. And depending on the season, we do notice an uptick in the phone calls where patients are worried about their symptoms. But yes, it's not just a change in color. It's often a change in consistency such that the stool is more difficult, and if I may be graphic, difficult to clean, or in a situation where the stool indicates that it may have blood in it based on how it looks in contact with other surfaces.
That's a good point. That's a really good point. And be as graphic as you as you need to be, or we're trying to share useful information. So let's go back to when you mentioned some lifestyle treatment. We talked about medications briefly. Let's talk about lifestyle, and specifically what can contribute to acid reflux first, and then we'll talk about some things that we can do to prevent.
Absolutely. One of the things that we've noticed is the increased frequency of patients presenting to our clinics with gastroesophageal reflux. And that corresponds in time to an increase in the obesity pandemic that we are experiencing in the Western world and, in fact, globally. And so by extension of that, added weight, particularly in the mid-abdomen, above a certain metric, is commonly associated with reflux. The other types of lifestyle changes that we would worry about is a more sedentary life, which we're all at risk for, especially during these pressing times where our activity levels drop. And as such, we have limited ability to assist the process of digestion. And then lastly, it's the timing and content of your meal. Many of us are in these very fast-paced societies and fast-paced job situation or work-life balance mismatch, where we find ourselves eating large amounts of food very late into our day and often sleeping very soon after that. Having a big, heavy dinner that does not include the healthiest of balanced food contributions can significantly lead to reflux.
Absolutely. That's a very good point. Those are all good things, and definitely things that in different stages of my life I've been guilty of based off of what I'm doing, how busy or stressful my life is. And it's particularly with the eating late and I think you'd mentioned the kind of foods that we're eating. Touching on that a little bit, can we go into maybe some specific triggers that can exacerbate or maybe even irritate someone who might have acid reflux, specific foods that if someone is diagnosed with acid reflux that they should be thinking about avoiding?
I have to plead some degree of ignorance when it comes to a careful breakdown of food and determining what the trigger foods are. And part of that stems from the variability or the difference amongst all of us. A food that might be considered safe to one person is not necessarily the best choice for another. My general approach to dietary recommendations is approaching things with moderation, partly because I'm trying to be conscientious of everyone's culture, background, and dietary preferences, but also because I want consistency. Typically, if we undertake a severe change where we eliminate something that we either enjoy or is part of our social fabric, then it becomes much easier to revert back to that when the circumstances are more stressful. And such that if you find that there are certain foods that are often associated with your symptoms, you should cut back. That said, there are some triggers that are quite well known, and those are often divided into categories. One such category is what and how it affects the gastroesophageal junction. There are some medications that essentially relax the gastroesophageal junction. There are others that cause some degree of bloating and abdominal distension and therefore generate pressure that pushes the acid up. But there are also foods that cause you to be hypersensitized, either by content of their spice or other chemicals, such that what would be considered a normal degree of acid causes you to feel more symptoms.
That's really good to know. You know, Dr. Taki, you really helped to break it down because generally speaking, we tend to throw out these, and even when you look it up online, there are these general categories: avoid acidic foods, avoid tomato-based foods, avoid caffeine, alcohol, etc. But I think that what you bring to the table with saying specifically, listen to your body, is what I'm hearing, is listen to your body. And if specific foods are irritating or worsening your acid reflux, go ahead and just leave them alone or reduce your intake of them. That's very useful.
And that's absolutely the case. And the other thing I'd add is if you're still having a significant effect of food causing your symptoms when you're on a medicine, that's reason to again see your doctor or consider another diagnosis may be considered. Mostly because these medicines are so effective at reducing acid that the effect of food should become much less.
Absolutely. That's such valuable information. Thank you, Dr. Ataki. We are going to continue our conversation in just a few minutes. You are watching What's Up, Doc on Muslim Network TV. We'll be back after this short break.
My wife, she's a professor at the University of Cincinnati, who's Catholic, and by her watching and listening to our 3-year-old son watch Adam's World, she ended up taking Kalima Shahada. She embraced Islam because she learned so much about Islam and the other prophets. It really affected our life in a great way, and because of Sound Vision and Adam's World, we're Muslims.
I took my Shahada 15 years ago, and I actually am from a rural part of Ohio. And so I found the catalog for Sound Vision, and I ordered the tapes and the CDs and the books, and I used those, and especially for my little daughter, that's how we basically learned our Islam, and Islam entered our hearts through the wonderful works of Sound Vision.
Okay, assalamu alaikum, brother. I just want you to know that I love the Sound Vision website, that a lot of times when I'm looking for information, especially as it relates to homelessness, domestic violence, and women issues, I go to that website, and then I see what you've written, and then I copy and paste it, and spread the word, because the wisdom is there, so I can't do any better than what Sound Vision has already done.
Sound Vision is our survival guide. It is the organization that provides skills for Muslims how to survive and thrive in this community here in the U.S.
Assalamu alaikum, my name is Anam, I'm in 11th grade, and I grew up with Adam's World, and what it taught me was unity, respect, and love for the Muslim Ummah.
Adam's World is the greatest show ever made. Take me to the Kaaba, man. I love that puppet.
Assalamu alaikum.
Open up your eyes.
Assalamu alaikum everyone, it's your brother Zain Bika from South Africa. One of the first educational programs ever produced for Muslim children was the ever popular Adam's World series. The colorful and comical Muslim puppet stole the heart of a generation. Sound Vision will be releasing brand new episodes of Adam's World with the launch of a Adam's World app. Subscribers will enjoy new Adam's World episodes as they are released, as well as all the classic episodes of Adam's World. So visit adamsworldapp.com now to learn more, subscribe, and enjoy new adventures of Adam and his friends, and let's keep helping tomorrow's Muslims today. Assalamu alaikum.
Adam's World. Believe me, there's a lot to see. Bismillah. Let's explore.
Welcome back to Muslim Network TV. You're watching What's Up Doc, and we're joined today by Dr. Otaki, and we're talking about acid reflux. So before the break, Dr. Otaki and I were talking about medications and the benefits or the benefits of medications, as well as different foods that can exacerbate or worsen acid reflux. Before we move on from that, I want to talk about medications or possible medications that may also contribute or lead to acid reflux, if there are any, things that maybe our audience should be aware of, to look through their medication list, and if they're having symptoms and it's not really triggered by food, perhaps they should be looking at their medication list.
An excellent question that is somewhat challenging to address, mostly because we don't completely understand the mechanism by which most people feel reflux. But in general, there are some well-known medications, such as certain blood pressure meds, that can lower the pressure of the lower esophageal sphincter, making you more likely to have gastroesophageal reflux. That said, it is quite rare to have symptoms dramatically improved upon a change in medications.
Okay, that's good to know. And before we move on from medications, let's talk a little bit about the long-term effects. I see a lot of people who take acid reflux medicine for years and years, and I'm always concerned when I read about the long-term effects of medication for acid reflux. Can we talk a little bit about if there is a specific duration patients should be using their acid reflux medicine before they start to need to be concerned about these long-term effects?
Absolutely. I must admit that this discussion, which will be limited to a few minutes, is often a subject of ongoing debate, such that we have daily discussions with our patients, but also is a topic that is getting a lot of press recently. And part of that has to do with the fact that these medications, while they're very safe, and I'll sort of briefly talk about the risk profiles that we're seeing, these are medications that are definitely overprescribed, and they are overutilized by our patients. And so the general principle by many of our societies that govern how we practice is to take the lowest effective dose in controlling symptoms. Now, in terms of the side effects associated with these medications, it's always important that you pair that with the reason you're taking the medicine in the first place, such that you are comparing the pros versus the cons, or the benefits pitted against the disadvantages or the concerns. And when you try to delve into that, if you have uncomplicated gastroesophageal reflux, the FDA-approved indication for the use of omeprazole or its equivalent medicines is often limited to 1 or 2 months. There are a number of people that have complications from reflux that need to be on lifelong acid suppression. And those include some of the at-risk group that we discussed, but others that have other known complications, such as strictures, persistent inflammation, or a transformation in the lining of their esophagus.
That's a good answer. So from what I gather, it's really a cost-benefit ratio that we're looking at. Generally, we want to use it for the smallest amount of time needed, but at the end of the day, we have to look at the benefit versus the potential side effects down the road.
Absolutely. It's a combination of cost benefit, but also a combination of health benefit, or another way to approach this is, what's the alternative? If you were to stop the medicine and have continued symptoms, are you or will you be considered for surgery? And how does your profile fit into patients who do undergo the surgery and their outcomes?
That is a perfect segue for where I wanted to go next, which is to talk about surgery. You had mentioned at the beginning, we talked about lifestyle, we talked about medication. Let's talk about surgery. So in thinking about surgery, what patients are ideal, and when should patients be considering or asking about surgery?
When we typically think of surgery, we think of the surgery that we've had for the longest track record or period of time, and that's what's known as a Nissen fundoplication. It is often paired with what is known as a hiatal hernia repair. Those are essentially one surgery where a surgeon, and I'm not one, so I can only tell you my experience as someone who refers to surgeons or who has seen patients who have had surgery. A surgeon, often using a laparoscopic approach, meaning very small incisions, is sort of able to dive into the area where the esophagus meets the stomach. When they are able to localize the area, they subsequently repair any defects in muscles or connective tissue. They then take the top part of the stomach and they wrap it around the esophagus to create a new, stronger valve, hence the common name, a wrap. Again, this is one of the surgeries that are available. There are other surgeries and technologies that we would consider minimally invasive interventions that have been explored. And while I'm happy to discuss them now, they tend to be more for a smaller group of people that have specific symptoms.
Yeah, if you wouldn't mind, let's talk about that just a little bit, because I think that it's very interesting that how you describe the surgery. And to me, it sounds like you're kind of reinforcing what already exists. So you're not really changing anatomy a whole bunch. You're really just reinforcing what is already there.
That's an excellent point. Yes, it's not a major reconstructive surgery as are others that we do in the gastrointestinal tract. Instead, it is augmenting or strengthening the lower esophageal sphincter using what is anatomically close by, which is your stomach. And in terms of the best patient population for the surgery are actually the patients who are most likely to respond to medicines, who have what we consider classical esophageal symptoms, and like many surgeries are the ones that are healthiest and most likely to recover.
Okay, that's interesting. So we're really not going for the ones that are going to have a negative or a poor outcome. We really want to pick the ones that we know will have a good outcome, because otherwise you're putting them through this surgery and the stress. We want to make sure that there's going to be success at the other side of that. That definitely makes sense.
And absolutely, to the point of our earlier discussion on the side effects of medications, these surgeries do have some side effects which are difficult to quantify, and they include the inability or the loss of the ability to belch, to vomit, and therefore they may infer certain...
Sorry to interrupt, but that doesn't sound like a bad side effect, the inability to belch.
It's valid, but I think what we often underestimate is that we all spontaneously belch or sort of release air on a daily basis. And if you lose that ability, then the air has to go the other way around, which is significantly more uncomfortable.
That's less socially acceptable. Okay, fair.
But no, I think the other part of this is these surgeries have progressively gotten better over time. And so it's not a one size fits all. A surgeon is often part of a larger healthcare team that's able to tailor that surgery so that it's a perfect fit for each and every patient who is a candidate for it.
Excellent. Before we wrap up, let's talk about, what happens if a patient does not treat their acid reflux. What are the long-term complications of acid reflux, essentially? What should patients be worried about?
Absolutely. The natural history of gastroesophageal reflux, if left untreated, is such that you are at risk of having certain complications. The most concerning population to many patients are esophageal cancer. And while the link is there, the percentage of people that have gastroesophageal reflux that develop esophageal cancer is very, very small. The science that we practice has not gotten to a point where we can accurately predict everyone who will develop cancer. Therefore, you have to maintain what's called an abundance of caution and a low suspicion, a low index of suspicion to proceed with a diagnostic test if you have any of the alarm signs we mentioned earlier. But again, I want to emphasize that the vast majority of people with reflux will never develop esophageal cancer, and it's important that you keep that relative context in mind as you explore other complications which are more likely. And those include a narrowing in the esophagus that can cause difficulty to swallow. Typically, that is treatable at the time of an endoscopy. Other complications include more difficult to treat asthma or sinusitis if those are existing problems.
That's very helpful, Dr. Ataki. So essentially not something that we should be ignoring, because in a subset of our population, there can be serious complications. And so if you are having symptoms, and as we mentioned, you've tried some of the things that Dr. Ataki mentioned, lifestyle, over the counter, brought it up with your physician, you definitely bring it up with your physician, essentially. You don't want to ignore this problem.
Absolutely. But also, again, emphasizing that because of how common reflux is, it's only the tip of the iceberg where complications happen. The majority of people are able to modulate their symptoms with lifestyle changes in the medications such that they never have to worry about it.
Absolutely. So there's usually a happy ending.
In most cases, if not all.
Good. Well, thank you so much for your time, Dr. Ataki, and for sharing your experience and your wisdom with us. We appreciate you joining us on our show today, and we wish you every success in your career.
Thank you, Dr. Al-Barwani. It's a pleasure to see you again, and I thank this wonderful show for involving me in this important discussion.
Of course. All right. Thank you. Thank you for joining us for another episode of What's Up, Doc. You can watch this and all our episodes on our YouTube page at youtube.com/Muslim Network TV and on our website, muslimnetwork.tv. Again, I'm your host, Dr. Aalia Al-Barwani, and I'll see you again next time on another episode of What's Up, Doc.